Okay, so thank you very much, Professor Hassan. I'm now very happy to introduce the next speaker, Professor Adel Shafik from Ain Shams University, Professor of Obstetrics and Gynecology, and he will talk about ESHRE guidelines on different types of pre-treatment in ART cycles. Professor Adel, please.
Thank you, Professor Mona, for the introduction. It's a pleasure for me to be here today in this elite and elegant webinar. Thanks to the EFFICACY for their continuous effort in continuous medical education for all the infertility practitioners in Egypt. Thanks to Professor Hassan Maghrabi for his kind invitation for me to be here today. My talk today will be about the ESHRE guidelines on different types of pre-treatment in ART cycles. To start with, why did I prefer to be an assisted reproduction specialist? Because it really combines being science and an art. It's really an art. It's assisted reproduction and it's an art. Very seldom we see two patients who are who are the same. Our patients are different patients regarding age, body mass index, and follicular count. So we need to individualize for each patient and her own strategy of treatment. Each ERT consultant would always like to think that his own recipe of pre-treatment and the treatment adjuvant is what gives him or her an edge, and it is the cause of his success. However, this might not always be true. We need to work on an evidence-based ground. So the question we want to answer today is: does hormonal pre-treatment improve cycle efficacy and safety for ovarian stimulation? Yes or no? The aim of hormonal pre-treatment is to suppress or reduce FSH secretion prior to gonadotropin stimulation in IVF cycle. Let's all please look at this fine graph showing the FSH level all through the menstrual cycle. At the end of the luteal phase, there is a sharp rise in the FSH level. This FSH level increases might be due to IO level or decrease in inhibin level, whatsoever the cause, but there is a sharp rise in the FSH level. This rise work on different cohort of follicles at the end of the luteal phase. These cohort of follicles have different FSH receptor concentrations, so the response of them will be different. When the cycle occurs and we are starting stimulation in the next follicular phase, we will be faced with different cohort oocytes at different phases of maturation. So the response to gonadotropin stimulation will be different. So the stimulation will be asynchronous. The follicles will be asynchronous. And this is a large problem that we face when we are going to give the HCG treatment, trigger of ovulation. So if the hormonal pre-treatment can cause coordination of the early antral follicles, causing less size and of variability and less discordant maturation of follicles, and hence easier clinical criteria for HCG administration, this would theoretically lead to more mature oocytes and more good quality embryos. That's why, or that is the purpose we might use pre-treatment. It will lead to synchronization of follicular development, prevention of occurrence of early large follicles, prevention of spontaneous premature LH surge, reduction of cyst formation. Last but not the least, it's very important for scheduling IVF cycles. It is very important for the practitioners, for the embryologist, and even for the patients to avoid working or doing ovum pickup at weekends. Pre-treatment therapies might include estrogen pre-treatment, progesterone, COCs, and GnRH antagonist pre-treatment, as we might see. Starting with estrogen pre-treatment, the ESHRE guideline groups focused on a Cochrane database review that was conducted in 2017 by a group of clinicians from New Zealand and Australia. Regarding the estrogen pre-treatment, they included 4 RCTs, including 744 women. The conclusion of this Cochrane review was that estrogen pre-treatment significantly led to more oocyte yield than the group of no intervention, than the group which didn't take estrogen pre-treatment. However, there was no difference between both groups in the rate of live birth rate or ongoing pregnancy rate or clinical pregnancy rate. As we all know, the live birth rate is the main determinant or the most important outcome for us. So the estrogen pre-treatment, although it increased the number of oocyte yield, yet there is no difference in the live birth rate. ESHRE guidelines reviewed another article, another randomized control trial that was published in 2018 by an Iranian group that wasn't published in the Cochrane database review. These are 30 women and compared estrogen pre-treatment with no pre-treatment. There was no difference in clinical pregnancy rate or number of mature oocytes retrieved. So the consensus of the ESHRE guideline development group was that pre-treatment with estrogen before ovarian stimulation in the antagonist protocol is probably not recommended for improving efficacy and safety. Now moving to progesterone pretreatment, and again, they depended on the same Cochrane review database. They included 4 randomized control trials, 421 women, and they compared agonist cycles and antagonist cycles. As regarding agonist cycle, progesterone pretreatment, when compared with no intervention, there was no difference between both groups in live birth rate or ongoing pregnancy rate. However, in the antagonist cycle, there was insufficient evidence to conclude anything. There was not enough data to conclude anything. So the progesterone pretreatment in the agonist cycle, there is no difference, while in the antagonist cycle, there is insufficient data to reach a consensus. Hence, again, the consensus of the ESHRE guideline development group was that pretreatment with progesterone before ovarian stimulation is probably not recommended for improving efficacy and safety. But here there is a very important trick because this guideline development group acknowledged that estrogen and progesterone are widely used for scheduling purpose, and this is probably accepted. So we can use estrogen or progesterone for scheduling purpose. They accept this, but we cannot use them in the view that will increase safety or efficiency of our IVF cycle. Now, moving to the most important and most commonly practiced maneuver in our practice is use of pretreatment with combined oral contraceptive pills. Again, this Cochrane systematic review conducted with compared 6 randomized control trials, and it has reached a very important consensus. In the antagonist protocol, pretreatment with oral will lead to a lower or less rate of live birth rate and ongoing pregnancies. And this is a strong evidence. There was no difference in ovarian nor in the number of oocyte rate. In my own practice, I used to use pills before any antagonist cycle for years, for ages, and I thought that this is a good practice. However, I changed my practice a few years ago, 3 to 5 years ago, and I no more prescribe oral contraceptive pills before antagonist cycles. However, there might be a small window that we can use oral contraceptive pills before antagonist in poor responders. In this special subgroup, when they have done sub-analysis, there was no difference in live birth rate or ongoing pregnancy rate or number of oocytes. So it might be used in poor responders. Again, as a trial came from the same Iranian group later after the Cochrane database review, and they found contraceptive pills. Hence, the ESHRE guideline development group, they conclude.
Could you repeat the last word, please? Because the connection is lost.
Okay.
Thank you.
So again, the Iranian group published in 2018 another study comparing 2 groups, one with oral contraceptive pretreatment, the other with no oral contraceptive pretreatment, and there was no significant difference in clinical pregnancy or number of mature oocytes retrieved. Hence, the ESHRE guideline development group concluded that COC antagonist cycle is not recommended at all because of reduced efficacy, and this is a strong recommendation. However, we must put some certain points. All the studies we have talked about, they have heterogeneous types of estrogen and progesterone. They were not using the same types of estrogen or progesterone. Again, they use them for heterogeneous duration. Some studies used OCPs for 12 days, others for 21 days, others for 28 days. Again, there was a heterogeneous washout period. By washout period, we mean the period between stopping the oral contraceptive pills and the start of our HMG stimulation. Some studies started it 1 day after, and some studies started it 5 days after. If you use after 5 days, then we have adequate amount of time to let the FSH rise, and again we have the heterogeneity of follicles or the asynchrony of follicles. If we started the next day, 1 day only washout period, then the progesterone component in the oral contraceptive pills might be detrimental to the endometrium in the very early follicular phase. So again, the washout period was not homogeneous in all studies performed. This might be a future study. This area needs further studies again. Now moving to the antagonist pretreatment. In the hope of, again, follicular synchronization, some groups started to use gonadotrophin antagonist in the early follicular phase before starting the HMG induction of ovulation, aiming to suppress endogenous FSH and LH. So when we give the HMG induction, we would have synchronous follicles. Moving to the evidence regarding this in normal responders, there is very low quality evidence that ongoing pregnancy rate and number of oocytes are not statistically different. So in normal responders, this didn't show any any effect or any difference. In poor responders, evidence still is controversial. Some studies show that this delayed start is beneficial, and some studies show that it's of no benefit. So the ESHRE Guidelines group up till now concluded or recommended that GnRH antagonist pre-treatment before ovarian stimulation, what we call delayed start gonadotropin, is probably not recommended. My take-home message is that pre-treatment with either progesterone or estrogen is probably not recommended for improving efficacy or safety. Very important to know that oral contraceptive pre-treatment is not recommended in the Antagonist protocol because of reduced efficacy. Guideline development group acknowledges that estrogen and progesterone are widely used for scheduling purpose, and this is probably accepted. Last, GnRH antagonist pre-treatment before ovarian stimulation in delayed start gonadotropin protocol is probably not recommended. Thank you very much, and I am wishing the EFFICACY best of luck in every webinar.
Thank you very much, Professor Adel, for an excellent presentation. Very brief, very clear. May I take advantage and ask you, we have a lot of experts here in Egypt that are still using oral contraceptive pills with antagonist protocol for synchronization. And they assume that the wash-out period is very important, and this is what is making results or the recommendation of the guideline confusing. So what do you do in your practice, and what is your response to this use of oral contraceptive pills up till now? And Professor Sonkara, if you want to comment also on this point after Adel comments, please, Adel.
In the past, I used to use pills for every antagonist patient, whatever her age, whatever her intrafollicular count or AMH. But in the past few years, I stopped using it almost in any patient. I start antagonist whatsoever without oral contraceptive pills. On experience, it didn't matter in the effect, in the results. It didn't improve nor make it detrimental.
So do you have asynchrony, or how do you come?
Of course, I have more asynchrony, that is for sure, but it doesn't affect the pregnancy rate at the end of the day.
Thank you. Professor Sonkara, do you want to comment?
Dr. Maharabi, with this question in the guideline, there was a lot of debate. In fact, we had to reconvene to discuss this particular question with another question. There was extensive debate because many of the guideline group experts themselves used in their centers the combined oral contraceptive pill for programming. So you're very right. As they're using in Egypt, it's used in many centers. And therefore, we had a lot of debate. And because they have said that in their, for example, the EV centers, EV Valencia, Ernesto Bosch from EV Valencia was one of the group members, and they use it extensively. And they've looked at their audit figures, and they said that they had no difference in the pregnancy rates or the live birth rates. The same with Nikos Polissos, who was working in DEXA. So there was a lot of debate, and there were a lot of emails. We had to reconvene to discuss this. But then we said we have to go by what is published, randomized data, and the Cochrane. So until further evidence comes up, we should be cautious and say that combined oral contraceptive pill, and we put in brackets the duration, is not recommended for programming. So at this moment, we said in terms of safety and efficacy, it is not recommended. And just as with colleagues in Egypt, we also have very varied reaction on this. But I think with this evidence, we should not be using any more, because if we get comfortable using the estrogen or the progesterone as pre-treatment, they're equally good for programming.
Okay, why should progesterone affect the results? How does it do that? Does it decrease live birth? Because now we are using progesterone for suppressing LH in freezing all cycles. So what does it do exactly? Why progesterone is bad? Adel. Adel.
Premature rise of progesterone, Professor Hassan?
No. Pre-treatment with progesterone.
Okay, pre-treatment doesn't affect it. It's almost the same result.
So it's not good. Sonkara?
Yeah, I agree with Dr. Shafik. So progesterone is fine for pretreatment as well as estrogen for pretreatment. So both of them are equally good. The only thing is when you give progesterone, perhaps you have to give a washout period, and it is better to look into your own center results and see how you want to modulate the protocol when using progesterone. But it does not decrease the pregnancy or live birth rates. It can be used safely for programming.
Excellent. I have a question here. The washout period depends on the formulation, meaning it is shorter with low dose E2. Does it differ with the type of oral contraceptive pills, the washout period that is needed? Dr. Adel?
Studies, as I have just mentioned, are heterogeneous. So they cannot be applied on every need its own washout period. So we should do a study for each type of oral contraceptive pill to determine the adequate washout period for each type of OCPs.
Dr. Sunkara?
Dr. Maharabi, I just want to make a comment before I come to that. As Dr. Shafik very clearly stated, and to all colleagues out there, with regards to use of estrogen or progesterone, either of them you can use for pre-treatment, we just have to remember that it is not for increasing the efficacy and safety. So what we
programming only.
Is only for programming. So if we are thinking that we are using it, although we are using it with the pretext that it will cause synchronization and improve the efficacy, studies have not really shown that they improve efficacy. So it's mostly scheduling or programming so that you can get your work program, but not for improving efficacy and safety. And that's what we need to stress to everybody.
Thank you. Dr. Tamer, any comment?
I agree with Professor Sunkara. It's just used in the context of programming for convenience rather than any pretext of increasing either success rate or decreasing hyperstimulation or anything.
Oh, I still have other questions about if you use estrogen, what is the duration of pre-treatment that you need to use if you decide to use pre-treatment with estrogen?
We use estradiol valerate 2 milligram twice per day, starting from the mid-luteal phase.
Phase. And you stop at menses or you don't stop at menses?
You stop once menses come and you start induction the following days, day 2 or day 3 from the menses.
Dr. Sunkara?
Absolutely the same.
Same.
So you can start in a 28-day cycle, you start on day 21, and then exactly as it will start. So once you stop the estradiol, you start the stimulation the next day.
But you stop the estrogen when menses comes or you don't? You wait for 1 or 2 days?
Because you're using it for programming, if you stop it when the menses come, then the whole purpose of it is not really. So you
correct,
can
yes.
however long you want, and then you stop it and then start stimulation long. But you don't continue it for more than 7 days after start of menstruation.
After menses or after occurrence of menses?
After occurrence of menses. So from day 1
so
of menses.
The max is 7 days after menses.
Yeah, but this is all what we are familiar with. There is no evidence or hard and fast.
Yes, of course. Yes, of course.
Yeah.
Tamer?
We start on day 2 or day 3 of the period, actually.
Yeah, so you don't wait for more than 3 days after period. Yeah. Dr. Sunkara, you wanted to say something?
Dr. Timur, did you say when did you start the progesterone? You start?
No, we start stimulation on day 2 or day 3
of the period.
Well, after we stop the contraceptive pill or we stop the estrogen, then we start on day 2 or day 3 of the period, start stimulation straight away.
Oh, I mean, we start the next day, but I think day 2 is also fine.
Yeah. Dr. Mona, any comment?
I actually wanted to ask Professor Adel what he does with cases with cysts, ovarian cysts. What do you usually give? Progesterone, combined pills? You wait another cycle? What do you usually do?
Usually I take conservative management and I start the next cycle. I will follow her next cycle. And
you don't give anything hormonal, just to make sure
in the past I used to give them pills, but I found it of no benefit. I stopped it since years. I just wait for 1 month.
I'm talking just about cysts. I mean, if you have cysts, not for programming, not for cysts. You wait for 1 cycle.
Yes.
Okay. Okay. Thank you.
Any comments, Dr. Tamer, Dr. Sankara?
Totally agree, 100%.
It depends upon whether it is a functional cyst or it is a non-functional cyst. So if it is a non-functional cyst, then you wait. If you wait and it still persists, and if it's a functional cyst, then probably you need to give something to bring about a withdrawal bleed or something like that.
Excellent. Dr. Gibril, do you have any comment? Ahmad.
As regards the cyst?
As
Yes.
regards pre-treatment, estrogen, progesterone, oral contraceptive pills, you're fine?
I'm absolutely satisfied with the answers.
Professor Mona, thank you very much.